Again, everyone. Thank you for joining us for the media briefing today and for your continued interest in what's happening with our health system as we make our way through the pandemic. My name is Taya Briley. I am the Executive Vice President for the Washington State Hospital Association. And today I am joined by two guests. The first is Dr. Krish Ladish, who is the Chief Clinical Officer of Pediatric Behavioral Health at Mary Bridge Children's Hospital, that is part of Multicare in Tacoma, and Dr. Santiago Neme, UW Medicine Clinical Associate Professor of Medicine and Infectious Diseases and Medical Director of UW Medical Center Northwest and Senior Associate Medical Director of UW Medical Center and Vice President of University of Washington Physicians. And before we hear from our guests, I wanted to provide some updates and then I'll turn it over to the two of them. We are happy to report that COVID hospitalizations are trending down with some decompression of hospital capacity. At the height of the Omicron surge on Friday, January 20th, we had a 7-day rolling average of COVID-related hospitalizations at 2,248 confirmed cases across Washington state. We've seen a double-digit percentage decrease in the number of COVID hospitalizations the past 4 weeks. There was an average of 960 COVID-confirmed hospitalizations this past week compared to the prior week's average of 1,248. And this is a roughly 23% decrease in a week, or an average decrease of 288 hospitalizations. We've averaged 103 new COVID hospitalizations each day this past week and roughly 10 to 15 COVID deaths a day. Of those in the hospital this past week, the average number of COVID patients on a ventilator was 62, which was a 31% decrease or 29 fewer patients when compared to the prior week's average of 91. So things are overall moving in the right direction. However, we do have a couple of counties that continue to be a little harder hit than others, and those include Pierce, King, and Spokane. Across the state, as reported through the Department of Health, the 7-day COVID infection rates continue to decline from 19,037 in late January to 1,459 as reported on February 21st. So we are thankful for these trends and that the downward trends are leading to decompression for hospitals. Washington State has also been bringing on long-term care decompression beds over the last few weeks, and that has also been helping. And as of the last week, there were 119 decompression beds in 6 different sites. Unfortunately, only 52 of them have been accessed and are being utilized. Hospitals and the state are working through the approval process to get more patients transitioned into these beds. However, hospitals are reporting that the criteria for admission can be overly strict, and a lot of hospital referrals hospitals have been making for these decompression beds have unfortunately been rejected. An additional 123 beds are coming online on March 7th, and we are hopeful that as we get a little bit further down the road that the approval process will become easier. So in addition to that, I wanted to share 5 things that we are tracking at this point of the pandemic response. First is that as hospital capacity improves, hospitals are working as hard as they can to get delayed surgeries, procedures, and services to patients who've been waiting for them. While waiting, patients have often experienced a worsening of their condition, so are coming in sicker, and this makes recovery more challenging. Hospital stays may be longer, and the burden on staff and families to support recovery might be greater. Hospitals are making decisions about how to work through the backlog using several factors. One is taking the most urgent cases first, including those cases that, if not done, could lead to disability or even death. But they're also considering how long the patient will need to be in the hospital and if there is a solid discharge plan. As we've shared over these past several months, it is challenging for hospitals to schedule procedures for someone who could wind up stuck in the hospital and take a room offline that other patients really need. Second, as we've discussed before, our workforce is exhausted and they are traumatized from their experience caring for patients and their families during this pandemic. And many hospitals are providing evidence-based trauma services and holding listening sessions with staff on how they can best be supported during this time. The long-term workforce solutions also need to be a focus, and it is our hope the Washington State Legislature follows through on initial indications that it will fund additional training slots for nurses and healthcare workers. A third thing that we are tracking is the weaknesses of public health and healthcare services that have been laid bare during the pandemic and need to continue to be addressed. We must ensure that we continue to focus on these areas going forward. And as you know, one of our specific areas of concern has been our long-term care system that is, and making sure that it is accessible and that it is staffed. We've seen short-term additional supports from the state in the form of beds. We just talked about those additional decompression beds that are coming online. And we've also talked about some additional funding that has been provided so that these long-term care facilities can adequately compensate their staff and retain their staff. However, the state is also poised to provide further budgetary support, and we are hopeful that it will be approved. As our population continues to age, getting this right is essential to the functioning of our healthcare system. Fourth, we are preparing for the possibility, or for the reality rather, that federal and state governments will begin rolling back the declared states of emergency. And we've already seen this start to happen. Oregon has stated that it will be lifting its state of emergency April 1st. This is significant to us because both federal and state waivers of laws have allowed the flexibilities that we have relied on to respond to the pandemic. Just to give a couple of examples, we have small critical access hospitals in our state. They are limited under both state and federal law to providing care to no more than 25 inpatients at a time. Most or many of them have been relying on the ability to flex above that number during the pandemic, and a number of them are continuing to do that right now. So we want to make sure that as these states of emergencies and waivers are lifted, that either there is some flexibility that continues to be provided or laws that are modified to allow increased flexibility in the future. Another example is hospitals that are providing acute inpatient services that are in patients' homes. They are relying on federal waivers and state approvals to do this. And as I said, our request to the state and federal government has been to provide us with ample notice if these waivers are going to be discontinued, and to consider on a case-by-case basis whether these flexibilities need to be codified into law or the flexibilities continued in some other way. The fifth thing that we are tracking right now is the announced end of mask mandates, which we understand in our state will be ending on March 12th. We both understand the desire to resume a more normal way of living with COVID and have some concerns that this could mean about what this could mean if COVID case trends begin increasing again. Hospital leaders are recommending that people continue to wear good masks when in indoor spaces. This is both for your protection and for the protection of our most vulnerable neighbors. Until we have a few months of really low cases and things are more certain, we ask that this practice be continued in a pragmatic way. It's an easy and it's a compassionate thing to do. And for those in our community who are immunocompromised or have other health conditions that make them more vulnerable to COVID, this is a small thing that can go a long way to keeping them safe. We are pleased about the new CDC, Centers for Disease Control guidance that combines 3 metrics to determine COVID-19 community levels. and they designate the levels at low, medium, or high, and then guidance is provided about what actions can be taken by community members based on those levels. And the metrics include new COVID admissions per 100,000 population in the last 7 days, the percent of staffed inpatient beds occupied by COVID-19 patients, and total number of COVID-19 cases per 100,000 population in the last 7 days. So the new COVID admissions and the percent of staffed inpatient beds occupied, those metrics represent the current potential for strain on the healthcare system. And then the data on new cases acts as an early warning indicator of the potential increases in health system strain in the event of a COVID surge. So we appreciate that the CDC put that guidance out there that adjusts recommendations on things like mask wearing and other preventive measures to be taken in the community based on those levels. And we hope that our state leaders consider implementing additional measures for our communities based on that guidance if it becomes necessary. So that concludes my portion of this briefing. Thank you, and I want to turn it over now to our two guests. You can go ahead and put your questions into the chat box, or after they're done speaking, you can go ahead and come off of mute and ask questions directly. And I am going to go ahead and start with Dr. Ladish. And Dr. Ladish, with this, I'll turn it over to you.
Great, thank you. I've been asked to speak both about the children who have been getting COVID and what we're seeing at multi-care with regard to that, as well as the impact on mental health within the context of changing mask mandates. And so first, to start in terms of children and COVID, I'll first say that I am not the infectious disease expert, nor am I a physician. However, I do know from the data that's been provided by our hospital that our incidence of children coming in with COVID has gone down. We have largely seen COVID presenting in children that are under 4 years of age, appear to be sort of the highest risk. You know, they don't tend to come in with underlying conditions. We have seen that they can be at risk with COVID for multi-system inflammatory syndrome, diabetes, some with encephalitis, and certainly, you know, higher risk for any kids that are vulnerable or immune compromised. We have seen also that there's been a little bit of a higher likelihood if we have kids that are coming in with obesity. And I don't know that we yet understand the specifics surrounding that, but that's been a factor that we've seen and that's been monitored. On the large part, I would say that our volumes are going down. We see that in the number of patients that we have in-house, the number of patients that have been on ventilators. And at this time, the numbers are much lower. We definitely saw our surge, however, during the Omicron variant, and so we continue to be cautiously optimistic. At multi-care on the whole, we have stood down our tents that had been brought in for overflow patients. Our incident command system, while it continues to meet, is reduced dramatically in terms of frequency. So I see those as positive signs that things are settling down and that the system does not feel in as much of a crisis state as it had been before, which is good to feel. In terms of the children response to COVID, we have definitely continued to see strong behavioral health volumes. And there has been a substantial behavioral health impact of COVID on children, as I believe most people are aware. We were in a mental health crisis long before COVID hit. And I believe, as with many other of our pandemics, COVID has shined a light on the pandemic of mental health challenges in children. We used to quote around 1 in 5 children suffers from a mental health condition. We're now quoting closer to 1 in 4. Approximately 30% of children during COVID have reported some type of anxiety or depressive symptoms. In our emergency rooms, we're seeing high volumes of children that are presenting with suicidality or suicide risk as the predominant presentation. Of our behavioral health volumes at Mary Bridge, 68% of those that have presented with some form of suicide risk or concern around suicidality. Key contributing factors to that, I don't think are surprising. Definitely the isolation and the manner in which it's pulled kids out of routines and has placed them away from many of the activities that buffer and offer protective factors against the isolation that they've been dealing with has been particularly hard. Also, fear of illness. Some of our kids have been rightly fearful of getting sick or losing loved ones. 175,000, probably closer now to 200,000 kids nationwide have lost a primary caregiver throughout this pandemic. So we are also seeing children who have lost at least one parent or caregiver. We're continuing to, try to move on things that can bring mental health resources and access where kids are being seen. So that includes partnering with schools, partnering with other behavioral health agencies, partnering with primary care to really help children get access where and when they need it. So those are some highlights. We're all keeping our fingers crossed. I've had people ask me, how do I put into context for kids the changing mask mandates? I think being truthful and honest and putting it within an appropriate developmental context is probably the best way to approach most things. And certainly COVID is no different. I think as we've seen, COVID has been a very fluid and rapidly changing virus with multiple variants. And we have responded to those variants with waxing and waning need for masks. And I think that is important for children to understand when they see that at times we're more urgent about it and at other times we seem that we can pull back a little bit. I also think it's wise to make sure that kids are remaining protected, hand washing, social distancing, masking in enclosed spaces such as schools, restaurants, et cetera.
Thank you very much, Dr. Ladish, and good advice for all of us to think about the need for adjustment and protective strategies during the ups and downs of this pandemic. Also, just your comments were causing me to reflect on how heartbreaking the impacts of this pandemic on kids are. We're still seeing 10 to 15 deaths a day from COVID. And these are family members, they're loved ones, they're parents. And I think we can get numb to the statistics, but these are real people. So with that, I want to turn over to Dr. Neme, and we'll hear about the infectious disease perspective.
Hi, good morning. Thank you for having me. I've been asked to talk a little bit about capacity management issues and where we're at in terms of the pandemic. At UW Medicine, as of 8 a.m. this morning, we have a total of 24 patients across all 3 hospitals. This is a significant drop from our peak about 5 weeks ago when we had a total of 204 patients across all 3 hospitals. For instance, today at the University of Washington Medical Center, we have a total of 11 patients. At Harborview Medical Center, we have a total of 7 patients. And at Valley Medical Center, we have a total of 6 patients. It's also noteworthy that only 4 patients of those 24 are actually in the ICU. The remaining 20 are in acute care, so also very encouraging. As you can see, this significant drop in COVID-related illnesses and cases in the hospital has really also been mirroring what's going on with community transmission. And for the first time in a while, we're under the high transmission level per CDC. So that's also very encouraging. However, one thing that's really occupying a lot of us really is the challenges that we continue to have in terms of capacity. And this is due to many reasons that Dr. Briley actually expressed, which is, it's a combination of the delayed care or pent-up demand. It's also the fact that as of February 17th, we've expanded again procedures, and now we're doing non-urgent procedures and surgeries as well. And also, we are a coronary healthcare system, so we continue to have a high number of referrals across the state for patients that we're still obviously very 100% committed to treat, and that really increases the volume of cases that we see. And lastly, I am aware that we're still having challenges in terms of post-acute services, but I'm aware that there's a lot of work going on in that regard. I would say, just following what Dr. Ladish was saying, COVID has really tested our ability to adapt and really respond to a situation. And I'm personally very proud of being part of this community, a community that has always focused on evidence and data and research and information, and really safety of our patients, but also our staff. Related to that, this is why we are continuing to require universal masking at our healthcare system. We also continue to encourage folks to continue to wear, and I'm talking about the general community, to continue to wear a mask when in indoor spaces. And that has to do with something that's been mentioned here too. It's not only my risk, it's the risk of my community, and we need to address it with empathy and with the understanding that we have a pretty significant amount of folks who, although they've been vaccinated and boosted, they're still immunocompromised, and their response to the vaccine is not as robust. So again, it's a little ask for all of us to really continue to do these measures, to follow these recommendations. Although we're entering a phase of non-mandatory masking, I do think that it's really important to continue to observe these recommendations that have really helped us save many, many lives and keep our community safer. And obviously, the other piece of advice that I would like to give is that if you haven't been boosted yet, please do it. Don't think that this is the end of COVID. Being boosted really decreases your chances of getting Omicron, of getting sicker, and it also protects the community. I would say that at UW Medicine, we're committed to continuing to care for all patients. We're continuing to look at the data and also participate in advanced research that sheds light to all of these issues. And again, it's all about adaptability, and it's all about understanding that pandemics are really fought as a community, and we are in really good hands here in Washington. Thank you.
Thank you so much, Dr. Nemi. Okay, I think that is it for the remarks that we had prepared. If folks have questions, please go ahead and jump in and ask them, or you can put them into the chat, and I'll wait just a moment for any that we have here. Okay, so here's a question for Dr. Ladish. Are we seeing kids and teens come down with long COVID?
So my short answer is yes. I do know that children are getting long COVID. I don't know the statistics on that in our state or within Marybridge, but I can certainly look into that and get that back to you.
Thanks. And Dr. Neme, when will you be comfortable calling COVID endemic? Just because mask mandates are being lifted, are we out of the woods yet?
Thank you. I think that's an excellent question. A lot of people are talking and debating about this. Typically, when we call an infection an endemic, really you want to see much lower numbers. We're still having significant number of cases in the community, albeit much lower and very encouraging. But we're still not at the steady state where you can actually anticipate when cases will rise, when cases will drop. And that way, when you drop and you're consistent, then we could start thinking about an endemic. And I hope we're there soon. But again, there's new variants and things to be followed. and really carefully evaluate that. And again, we're committed to doing that and making sure that everyone gets the best advice and the most accurate information.
Thank you. And a couple of questions coming in about the lifting of the mask mandate. The first is, are you concerned that the end of mask mandates sends a mixed message that will get people thinking it's okay to just go unmasked? And I'll be honest, I think that we at the Hospital Association are a little nervous about what the impacts could be. I think we should have our experts weigh in here. One of the anecdotal stories that at least we have been hearing relating to schools where mask mandates have been lifted is that kids may start out continuing to mask and then with sort of trends and peer pressure increasingly wind up unmasked and transmission rates go up. So that is one anecdote that definitely caught my own attention. So Dr. Neme and Dr. Ladish, please weigh in with your perspectives.
Yeah, so it's a really great question. I too am concerned about the lifting, but at the same time, we've been in this pandemic for over 2 years. The cases are dropping. I think it's naturally to follow the evidence and really adjust what we're doing. And I do think that it's going to be something that we need to evaluate. And again, things might change if we start seeing more cases or more hospitalizations or more people ended up really sick. We're committed to following that. And it is somewhat of a concern for me as well.
Yeah, I would agree. And I think that the way I would approach this is just to really think of it as this is where we are now, given the data that we have now and the case rates that we have now and the effectiveness of the vaccines at this time. I think, if things are shifting, then I would expect that some of the recommendations would shift as well. And so I think it's important to say that, at this snapshot in time with all that we are seeing, people are feeling comfortable making this decision. That doesn't mean that as a state, we won't adjust should the situation or status change.
Thank you, Dr. Ladish.
If I may add, I also wanted to say that I think our perspective in healthcare is also influenced by the fact that we are caring for patients, and a lot of our patients are unvaccinated or are immunosuppressed. So it is really important for healthcare workers to continue to adhere to masking indoors, for instance. Now I'm also reassured by the weather is turning to be nicer. So I hope that people, instead of gathering inside, are gathering outside and can start socializing and connecting, because this is really important. And it's something we haven't really done for a long time, or we've had periods where we've been able to do it. But I do think that it's shifting towards the spring and the summer where things are going to be more outside. And therefore we may get a little break also from that regard. So it'll be something that we need to continue to study and see where we end up. But I'm confident that we will make a shift if we need to. So with the main goal of keeping the society safe.
Thank you, Dr. Neme. And the next question really kind of gets to that, being able to be fluid in our response. The question is, it sounds like hospital leaders are advising people keep masking if able, despite mandate changes, but wondering how you're feeling about changing your masking behavior in different parts of the state, depending on risk level. And I do think that that's something that we're going to need to develop maybe a little bit more of a comfort level with. We've had pretty clear, strong messages about, masking for the last several months. And so perhaps being more fluid in masking behavior or social distancing behavior is something that's going to be a little bit newer. So Dr. Ladish or Dr. Neme, if you have any other comments on that, please hop in here.
I don't really know what to say about. I mean, I think it's a complex situation, and I think people will have different levels of comfort with that. You know, and it's hard to determine where are those you know, geographical borders where risk shifts. You know, I'd like to imagine it's probably not black and white in terms of making that decision, and so my sense is that people will make decisions potentially more on a personal note, possibly than on you know, a note based on risk in various parts of our state. But I think that has yet to be seen.
Yeah, I personally, so what I would say, because it's very hard to know who is vulnerable, who is not, who's fully vaccinated and boosted, and who is immunocompromised. I haven't really changed what I've done throughout the pandemic since the day we started with universal masking, UW Medicine, and the mandates. I continued to do that. And again, I think it has to do more with, it's almost like a culture now that we've acquired where someone knocks on my door, I'm going to put on a mask and I expect the person to have a mask on. Or if I'm caught without a mask, I feel like I have to put on a mask. Mm-hmm. So in a way, it's almost something that I don't think about as much. Mm-hmm. And it's part of what I've done and what my family has done. And again, my angle could be a little stronger because I'm in infectious diseases, or maybe because I've cared for some of these patients. But at the same time, I think it's a very small thing to ask people to continue to do. And again, not in a mandatory way, but in understanding that this is beyond the individual level, is more of a plural effort.
Yes, thank you very much. I know that feeling of being caught without a mask. It sort of feels like, oh, some piece of my ensemble is missing. Mm-hmm. So I'm going to hop to another question about hospitals and masks. And the question is, do we anticipate that hospitals will be continuing to require masks after March 12th? I think that is a strong expectation. I see nodding from our guests as well. Great. And then there is a question about, can I expand more on the flexibilities hospitals want when the emergency declaration is rescinded? And can I give an example? So there are a number of flexibilities that hospitals have been relying on to support the pandemic response. One example is that 25-bed limit for our rural critical access hospitals. Right now they have the ability to care for more than 25 inpatients at a time if they need to. That has been absolutely essential in our being able to manage very, very high hospital capacity across the state. At the height of the Omicron surge, we had a number of our major hospitals and health systems that were running, 130%, 150% capacity, which means that for the hospitals that are often referring patients to those bigger centers, they need to be able to hold on to patients that they would normally transfer. And they might get some additional support from by telehealth from some of our more expert physicians or team members to manage those patients in place at one of the smaller facilities, for example. But that being able to be over that 25-bed limit has been absolutely critical. And if we get another surge, which seems like, it may be in the cards. We hope that it's not, but it may be, given our experiences with COVID. Being able to have that flexibility is going to be really important. And then another example is what's called this hospital at home. We have some hospitals that are taking advantage of this. Again, it's an important decompression strategy for our acute care centers. And in using these strategies, hospital patients are actually able to receive acute care services in their homes. This is different than home health care. This is more intensive with nurses and therapists and lab services available to hospital patients actually in their homes with the same level of monitoring and care, but that patient is also not in one of our acute care beds in the hospital. And so those are two really important strategies that have helped take pressure off of our inpatient services. And we are going to be really interested in knowing how that's going to transition going forward. So hopefully that helped answer the question. Let's see, we've got another couple of questions here. Could you update us on the status of the state staffing bill? Does the Hospital Association approve of the amendments made to the bill? So the SAFE staffing bill, or House Bill 1868, right now, we believe is in the Ways and Means Committee in the Senate and has not moved out of the Senate. We have had very significant concerns about this legislation, as well intended as it is, and as much as we agree with the need to make sure that our frontline caregivers are receiving all the support that we can possibly provide them. This has been an extremely challenging pandemic for these frontline caregivers. We do not think that strict nurse to patient ratios is the answer for how we move forward with our healthcare system. It is really concerning to us that there would be these strict limits that would prevent hospitals from having the type of flexibility that they need in order to care for patient surges. During Omicron, if there had been these strict patient ratios in place, we would not have been able to surge and care for everyone who needed care. And I may have said this before, I think all we need to do is look to our neighbors in California to see the experience of what ratios can mean in terms of needing to turn patients away from receiving care. The specter of ambulances lined up in the streets of Los Angeles, unable to get patients into beds is an image that haunts me, actually. And sort of it's in my mind as I think about the potential implications of this bill. So Washington hospitals are coming together and really looking at what further can be done to support frontline caregivers, and importantly, to build the pipeline of nurses. We are advocating in the state legislature. We would really like the state legislature to shift its focus to building this pipeline and allocating the money that needs to be spent in order to make sure that we have more frontline caregivers to care for our population who needs it. So I hope that's responsive to the question. And I see another question here about shifting towards, do we anticipate shifting towards an endemic phase that will slow the demand for travel nurses in the state? And how long do you see hospitals requiring temporary nurses? I would love for our guests to weigh in with any perspective that they have. I think that, it's evident to everyone that the pandemic has had major repercussions across the entire country's workforce, and that is not limited to healthcare. But for those of us in healthcare, we really want to focus on starting to rebuild our workforce and shore up our workforce, which was, we didn't have enough nurses and workers even before the pandemic, given demographic shifts. So my hope is that as we see COVID starting to move to something that's a little less dramatic in terms of peaks and valleys, and our healthcare system stabilizes, that temporary nurses will be needed less. But as far as the timetable, I'm not sure. So Dr. Neme or Dr. Laddish, please jump in here.
Yeah, I would say I think, I hope so too, and I think that's likely the case, that when we reach more of an endemic phase, we will have more permanent staff. I have some reassuring signs right now where we seem to be hiring fewer travelers than we were, say, 3 weeks ago or 6 weeks ago, definitely. So I can see how that trend should continue. But I do want to say that there are many factors. I think we could never underestimate the effects of burnout on our healthcare workers. But I think like having that workforce again that belongs to the facility, that belongs to the team and the culture will help us also go back to basics, go back to things that we used to do prior, or let's say we used to do more of prior the pandemic, right? Things like focusing on CODI prevention and other things that we all want to have again. And I think we now have a bit more time to focus on all other measures, readmissions, et cetera. So, and that really relies on having a steady workforce who's actually part of the care teams and the organizations. So then folks do not have to relearn everything every time there's a new person, and then things can fall through the cracks. I do see some reassuring signs right now, and I hope that they continue to improve.
Yeah, I would only add that I think the workforce or training to workforce pipelines are going to be very important in our state and continue to be. I think, the nursing workforce was an issue, and, our nurses were stretched then prior to COVID hitting. And so I think this has really sort of added a big blow to that. And my hope would be that we can continue to do the right things to maintain our workforce and to bring on more workforce. I know that we all want to get there.
Yes, for sure. Thank you. And then I think a very astute question here. We talk a lot about back to normal, but are there ways that hospitals and our health professions have been permanently changed? Will hospitals be able to get back to what they were like pre-pandemic? And my initial reaction to that is I don't think we're going back from the expansion on telehealth that we have had. That has been a dramatic change in how healthcare services are delivered, and I think that is for sure here to stay. And I think one of the other things that is here to stay is that care models are going to need to change. We have, sort of had these traditional care models, and we've had to become a lot more innovative using various types of caregivers differently, and caring for patients in different settings. I think that's here to stay too. So Dr. Ladish, Dr. Neme, what else would you add to that?
I think that, individuals as consumers of healthcare, that's a whole other area that we need to be mindful of in terms of the impact on hospitals and how services are utilized. I think there was already a trend towards, increase in use of ambulatory centers over hospitals. I think that is continuing. And so I think when we talk about, getting back, I really encourage to think about we're moving forward to our new normal is really how I think about it. I think there is no going back to where we were. But I also like to encourage people to remember that there, as you pointed out, telehealth. And I mean, there were some advances that we made incredibly rapidly and continue to make as a country that we would have never moved to were we not forced to in light of this pandemic. And so I think that I'm not sure we want to go back to where we were before. I know there's a lot of things that we will happily embrace when we get there, but there are also a lot of learning lessons that we take with us and that we can bring into our future.
Yeah, no, I completely agree. I would like to add that, COVID has really rocked the world. No one is the same. So it's been really devastating for a lot of people. A lot of people have died. A lot of people have been ill. But at the same time, I agree. I think we have areas where we've grown as a society. We've also identified, I think, areas where we need to continue and do more about, like wellness, well-being, like satisfaction of our patients and the staff, to make sure that people have what they need. I think that although we've gotten more Zoom, we've also been able to connect with our staff in a more intimate, I would say, personal manner, where people could voice what they're feeling, what they need, what they're thinking, the challenges that they have. Because my struggles may be completely different from someone who is an ICU nurse, spending, doing very long shifts, coming back to a home with 3 children, right?
Mhm.
So it's been really interesting and important and meaningful to learn about how people have experienced this and what it is that will keep them going and engaged and supported. So although it's been clearly devastating, we have areas of growth. And I think that no one is really the same. And I hope to, again, as you both mentioned, that we continue to build and also retain some of that speed, some of that efficiency in making decisions that don't necessarily require 10 meetings over the course of 10 months, right? Decisions that were made in 48 hours with 10 meetings, but all back to back. So I hope that we retain that and that we continue to focus on our patients and throughput, because ultimately we want to be able to have the right patient in the hospital, the patient who really needs us and needs us for that phase and their care. We don't want, we don't want to be treating patients who need to go to a clinic instead. We want to really hone in what's appropriate for the hospital setting, what's appropriate for clinics, what's appropriate for home, in home, etc. So I think that I'm actually excited about the new phases that are coming. But again, I remain cautious because we've had already 6 surges in Seattle.
Mhm. I think the pandemic has also, provided a common stressor, right, that we know all of us are confronting. And so it's opened a door for discussions around those impacts that we might not otherwise have. And I hope that that openness around emotional wellness and well-being continues in all spaces. I think that has been a healthy thing for us, an essential thing for people, for their coping and for their resilience, to be able to talk about the stress factors influencing them at home, at work, wherever they might be. And I truly hope that that continues, because I think that's absolutely essential.
Thank you very much. I don't see other questions in the chat. Hopefully I got to all of them. Are there any other questions for our panelists here? Okay. Well, with that, I think that we are concluding a bit early today. I take that as a good sign that maybe we're headed for a quieter phase here. I want to say a big thank you to all of you who have been attending these briefings so diligently and helping us communicate out to our community what is happening with the health system. I want to say a big thank you to Dr. Ladish and Dr. Neme for joining us today. And we will see you again soon. I don't know if we have another briefing scheduled. Let me just pause. Beth, do we have another one on the books?
We don't. With the surge waning, we are going to pause our regular briefings, and then we'll come back if COVID requires it.
Okay, thank you, Beth. All right, well, in that case, I will say, I hope we don't, as much as we like you, I hope we don't need to see you again soon, but do really appreciate your engagement and interest. Bye, everybody.
Thank you.